Um, Hello to everyone that's streaming virtually, but I wanted to go ahead and get started, of course, with my introduction. Just really briefly, my name is Kiana Dixon. I may or may not have intentionally matched with my slide deck and the event today, but I'm a pharmacist by background, by education, and by training. I worked in nuclear pharmacy and in community pharmacy before I made the switch into curriculum design and content development specifically for the life sciences. You may have heard of ACMA. I'm actually a life sciences associate with the Accreditation Council for Medical Affairs. And what that means is we're just establishing the standard of excellence across the board, across the pharmaceutical industry. We work a lot with pharmaceutical industry organizations, with hospitals and clinics. And within that division, we work with the National Board of Prior Authorization Specialists, where we develop and have drive the content for the PACS program. So you're probably familiar with PACS, the Prior Authorization Certified Specialist Program. If you are PACS certified here in the audience today, we actually have a treat for you all. We are providing, there's one, there's two, there's three, we got a couple. If you're PAC certified, we have a treat for you. You can remember every 3 years you have to recertify to maintain your license and maintain your board certification. So if you're here in the audience, you're actually eligible to apply 2 CE credits and apply it towards your recertification. So you have to complete 10 CEs for that recert, but we'll provide you with 2 today for attending this session. Now, if you're not PAC certified, you want to, you've been thinking about it lately, we still have a treat for you. We can actually apply a 10% discount code to your enrollment. And if you have more details, if you have any questions, visit the website here, priorauthtraining.org. And that's where we have all the details of where you'll find the CE credits and where you find that discount code. If you have any questions about the PACS program, of course, I'll answer those questions at the end, or you can find me somewhere here at the summit here over the next week. I have on this bright orange suit today. I'm sure you can find me, and we can talk one-on-one. Now we're driving more to what we'll actually be talking about today. So prior who? The authority behind prior authorizations. So today we'll actually discuss the current workflow. What does the prior authorization process look like? So we'll take a look at a snapshot of that process. And then we'll go into the different players in that process. What role do they play? What does their journey look like? And then we'll also go over the improvements. How can we improve and impact their journey so that they have a positive experience? Now, here's my simplified version of the PACS program or the prior authorization process, right? So we have a lot of colors here. I obviously love color. We have a lot of pictures, a lot of names here. But today, my goal is for you to be able to answer the question and to hold your own in a conversation or in the debate whenever prior authorization comes up. A lot of people have a lot to say and a lot of opinions on how we can make this process better. But today, we'll go over each player in the process. So each player, here by my definition, they're affected by the initiation of, the submission of, or the determination of a prior authorization, and they help spur along that process. So everyone here, we're here at the Healthcare Advocate Summit, whether you're here in person or you're listening in virtually, you're a healthcare advocate. Answering that question of how can we provide timely, safe, effective, and affordable access to evidence-based care to all patients, but also reducing those burdens, those administrative burdens that we have to overcome as healthcare providers. So again, as healthcare advocates, we know that main goal, our end goal, our motivation is the patient. So this is obviously our key player in this process. And we'll actually take a look at every single player here, the patient, the physician or the provider, the pharmacy, whether that's specialty or retail, and also, of course, the payer, the insurance, the health plan. And then we'll go over what all these arrows mean. So just as a brief overview, the white arrows will show and exhibit what the patient goes through or their journey through this process. The red arrows show the rejection. They show the requirement of a prior authorization. And then we see these green arrows, and the green arrows show the notification of approval of a prior authorization. So let's take a look and we'll zoom in first at the patient journey. All right, so I'm going to paint a picture for you. You can also use this as, imagery, but picture of a patient. What happens when they go to the provider and how they end up in the prior authorization process in this chain and wheel of more information, calling, status updates. So the patient, they go to their physician, right? They're feeling sick, they're not feeling well, whatever it may be, they're going there for a yearly checkup, and the physician, they write them a prescription for a new diagnosis, they write them a prescription for a new script about a therapy or a medication that they've been on for the past 12 months. Whatever it is, the patient feels hopeful, right? They have this prescription in hand, they're ready to go to the pharmacy. They're ready to start making an initiative and some type of change in their own health. And so they're feeling hopeful. They go to the pharmacy with that prescription, or they get to the counter and they're ready to pick up because their prescription was sent over electronically, yay, e-scribing. Um, Either way, they meet to the counter, the pharmacy technician or that pharmacist. And they get there to the counter ready to pick up just for the pharmacy to say no. The pharmacist that they're speaking to, they say, hey, sorry, we can't fill your prescription today. Your insurance, they rejected it. Your physician, they have to send in some type of information. They have to send in something in order to gain that approval. Now the patient, they're kind of confused. The patient is lost. They were very hopeful. They came here to pick up their prescription medication, and now you're telling me no. Now you're telling me I can't get it. The patient, again, they're feeling very confused. As a pharmacist, I actually stood on the other side of the counter having this conversation with those patients, especially in retail or community pharmacy. They're not expecting this, right? So they ask these common questions. Why didn't the doctor mention this? What information is needed? What can I do? Patients, they feel like prior authorizations or whatever information there is, that is within their control, that they can do something, that they can send something in. And the more you try to explain the process, the more confusing it really can get. They ask, is this normal? This is their first time ever hearing of this term. And so now they think that they're the ones out of the box. They feel as if they're the ones that are different. They maybe think that their physician did something wrong. Maybe the pharmacy did something wrong. They just feel confused. You can imagine, just from the patient's point of view, healthcare and health jargon, medical terminology is already confusing enough, even if you do have clinical knowledge. So then if you mix in the language about payments and reimbursement, now they're even more confused. Again, even if you don't have that clinical knowledge. Now, everyone's probably already seen this huge number and this fact in the AMA prior auth survey, but 93% of physicians report that treatments that require prior authorizations, they delay access to patient care. Now, with comorbidities on the rise, can the healthcare system, can we really afford, really ethically and morally, for 93% of treatments to be delayed, risking worsening their disease state? Can we really afford that? So what's next in the patient journey? So within every player that we go over today, we'll go over their journey, what that journey looks like, and we'll also actually go over their outcomes. What are those possible outcomes of that journey? And what are ways that we can improve their journey and impact their journey in a positive light? And then across at the bottom, I have where in the PACS program we actually discuss these improvements. All right, so let's shift back to the patient journey. So what are the outcomes? What can happen for the patient? So first, of course, our ideal outcome is always the patient receives their treatment, right? Whether that's delayed, whether they receive their medication or therapy right at initiation, that's the ideal outcome there. Next up, treatment is abandoned. Patients, they have lives, they have work, they have families that they have to deal with, well, not deal with, but families that they assist with, right? They have a life. And so they keeping up with this constant process of calling the pharmacy, calling their healthcare provider, calling their health plan, it gets tiresome. It's burdensome on the patient as well. And so I've seen commonly that patients just say, well, forget it. I don't feel like going through this. If I really need it, I'll get another prescription when I go to the physician the next time. Next here, this first bullet, you see, we're discussing community pharmacy, specialty pharmacy, mail order. When I worked at the community pharmacy, A lot of patients, they don't understand what specialty pharmacies are. They don't understand the extent of pharmacy itself and what a pharmacy can really do and what they cannot do. And so having this juggle between community pharmacy, transferring it to a specialty pharmacy, possibly sending it to a mail order pharmacy in order for it to be filled, it's a hot potato game. It's a hot potato game of a prescription, and they're lost. Again, the patient has no idea what's going on. So how can we improve the patient's journey? All right, so the first being health plan transparency kind of ties in with taking your communication steps proactively. So, with health plan transparency, with the rise of specialty medications and specialty medications, you'll see a fact later that in 2023, I believe 2 out of 3 drug launches will be specialty medications. So, from the payer side, it's more important to let the patient know what specialty pharmacies are included in their network, which PBM approved pharmacies are available to you in your area. That's more important to know for the patient than their retail pharmacy because we know there's a retail pharmacy on just about every single block nowadays. Take communication steps proactively. Again, this is increasing communication, this is increasing transparency, and taking those communication steps proactively and letting the patient know at the site of point of care what a prior authorization is. Within a provider, especially in the outpatient setting, you're aware of which medications that you encounter that commonly require a prior authorization. If you plan to prescribe this medication and provide that to your patient, go ahead and let them know at the point of care about this process. So then we avoid that surprise, we avoid that confusion when they reach the pharmacy counter. Alrighty, so we're back to the simplified process. So we went over the patient's view and their journey. So they went to their physician or their healthcare provider, and then went to their pharmacy. The other arrows that affect the patient are these green arrows. So remember that the green arrows, the arrows of notification, notification of approval. And if we follow these green lines or green arrows, the green arrow starts with the payer, of course. The payer lets the physician know, who lets the pharmacy know to go ahead and fill that prescription. And then the pharmacy finally calls the patient and says, hey, we have your prescription ready for pickup. You can come on and pick it up. And that's how the patient finally knows that this process is finally at an end, that they finally approach gaining their medication. So again, following the patient journey, let's go ahead and take a zoomed in focus to the physician. So for the purpose of today's educational session, the physician or the provider, when I discuss these providers, are in an outpatient setting, not the inpatient setting. All right, so the physician is left confused. Let's go through the journey and I'll paint the picture now for the provider side. What does their journey look like in the prior authorization process? So the physician, they had a patient, they wrote a prescription, and they sent their patient on about their merry way, right? They went on about their daily business. But then the next day, a few hours later, they get a call, whether that's from the pharmacy or from the patient. Hey, I tried filling my prescription. They told me that you did something wrong. They told me that you did not submit in the correct information that was needed. So now the provider and their staff, they have to go through the patient's EMR. They have to find information to substantiate a claim for prior auth. They have to submit that claim. They're also fielding questions from the pharmacy all the time. Hey, can we fill this prescription? Hey, your patient called us again. Can we fill this prescription? They're fielding all of these questions while still seeing all of the patients that they have to see on a daily basis. I'm sure you know this number also. Physicians and their staff, they spend an average of 13 hours in 1 week just completing prior authorizations. So this is a lot. You know, as a physician, as a provider, spending this much time on administrative tasks, again, they're burdensome. But that's not what it's all about. Remember, we mentioned even here, just healthcare advocates, we know that it's about the patients. These 13 hours, yes, is very frustrating to complete those prior authorizations. Yes, it's very burdensome. Yes, it's very annoying. But those 13 hours could have been spent rather on direct patient care instead of on these administrative tasks. What's next for the physician? So I'll spend some time a little here on the outcomes for the physician. The first being complicated decision making. Again, with ACMA, we speak with a lot of organizations, a lot of teams to to better their workflow, to better their processes when it comes to processing prior authorizations. And recently, I actually spoke to a pharmacy, the head of their pharmacy department, and we're discussing their current process. What does it look like? What barriers they currently have when it comes to prior authorizations. And they have this one provider who always wants to prescribe this one prescription, and it always undergoes a prior authorization. And instead of having to go through that prior authorization process every single time, instead, he just writes for another therapy that's been around for a while, just so that he doesn't have to go through the administrative burden of going through those prior auth tasks. And to his point of view, he's helping the patient because now the patient at least has something. At least they're not waiting for some therapy. But the issue there is you're avoiding that evidence based care that we need. You're avoiding what those first lines are when it comes to clinical practice guidelines. So, with this complicated decision making, with prior authorization process being so debilitating and burdensome, some physicians are shying away from specific therapies that may be most beneficial to their patient solely for the reason of avoiding that prior authorization. Next, we have a cycle of labor costs. Labor costs are also an outcome on the provider side. So within the provider's office, I created this little example really quick of just labor costs, right? So let's start here in the middle. And the provider's office, they're starting to see an increased number of prior authorizations. They're spending 13 hours a week or more solely on this prior authorization load. They're focused on billing services. This is all that they're really doing throughout the day for administrative tasks. In order to go ahead and focus more on patient care, sometimes they try to hire more staff to handle that load of prior authorizations. These staff members are medical billers or coders, just people who are solely dedicated to only completing those claims for prior authorizations. But of course, with increasing your staff, that's an increase of money coming out of your pocket, right? You got to pay for these salaries somehow. So, how do they offset those prices? They begin to welcome new patients into their practice. They're opening their hours, they're opening more time for more patients. But of course, with more patients, there's more therapies, and there's more of a likelihood and a possibility of running into a prior authorization. More prior authorizations, let's get more people to do those prior authorizations. So we're in this continuous cycle. It's on and on and on. All right, so how can we improve the physician's journey throughout the prior authorization process? So first we have prior authorization processes and workflow. With portal key codes, for example, some provider offices are very selfish with their key codes. They don't want to share them with anybody, right? Here you can compliantly share those key codes with other staff members in your office, with pharmacies, so that they all can be transparent in the status of those prior authorizations. When it comes to EMR documentation, I have here it's best to include more than not enough, right? Make it easy on your staff. Make it easy for them to locate the information that's needed. If they're hunting for this information, they're bogged down with time every single prior authorization. Of course, educating your staff. With educating your staff, certifying your team, they're now more knowledgeable when it comes to prior authorization, more understanding of insurances, patient assistance programs, whatever hub services are available. They're able to know and feel comfortable with the reimbursement landscape so that they can provide a timely submission for these prior authorizations. Alrighty, so we looked at the patient, we followed their journey, and we looked at the provider's office. What did that look like? Now we're moving on to the pharmacy where we see that those red arrows start. So these red arrows again are notifying of rejection, a requirement of a prior authorization. Of course, I'm biased here and I'm excited about this section because I'm a pharmacist, but we'll go ahead and take a look and I'll paint this picture on the pharmacy side for you. Right, so pharmacists, they get this prescription come in, they have a pharmacy tech or they go ahead and enter that data into data entry on their own. They try to process the prescription through the insurance. And then, boom, adjudication, the fun word. And so adjudication comes across, and when the patient comes to try and pick up, They can't pick it up because insurance has blocked it. It requires a prior authorization. So specialty medicines, they're on the rise, right? We all know what specialty medicines are. And now they account for 56% of medical spending. This is up 28%, up from 28% just a decade ago. So we're seeing that these therapies are on the rise. Of course, we can attribute these to autoimmune therapies, new oncology therapies. They're on the rise. So we have to do something with the market access for these medications. All right. So the pharmacy, continuing on to their journey, the pharmacy is unsure of when to reprocess the prescription, at least from a retail pharmacy standpoint. They're unaware, they don't get that notification from health plans, not the common health plans. They don't get that notification until the physician has called them. The physician has called them and let them know, hey, we have the notification. Can you go ahead and reprocess and fill that prescription for our patient? Now, while all of this is going on, the pharmacy, they're the most accessible healthcare providers, right? So it's very easy for patients to call up their pharmacist and speak directly to their pharmacist rather than their physician. So they're calling constantly. What's the update? I've been calling for the last 2 weeks. Why is my prescription not filled? They're fielding these questions from the patients, and all the pharmacy can really say is that, hey, you'll have to call your physician about new information. We don't have that information or that update. So what's next? What occurs next? What outcomes do we see on the pharmacy journey? Who and what is a specialty pharmacy? This is what the patient asks, right? Patient has no idea what a specialty pharmacy is. This is not a common term for them. We start to see this cross communication between pharmacies very often because of pharmacy transfers. Just like the patient is unaware of what particular specialty pharmacy is approved by their health plan, similarly, providers, they're also unaware of which PBM approved pharmacies are approved for their specific patient. So what happens is the provider, they just write a prescription, they send it to whatever specialty pharmacy that they've elected to work with at that time, right? So that pharmacy accepts the prescription, they type it up into their data entry, they process it just to see, hey, we're not approved by this insurance to even fill this for the patient. What can we do? Well, this is a specialty medication. Let's go ahead and try and send it to a specialty pharmacy, a PBM approved pharmacy. Pharmacies are usually aware, of course, of which pharmacies in their area accept which insurances. But once that transfer is sent to the PBM approved pharmacy, many specialty PBM approved pharmacies do not accept transfers. They want a new, fresh script from the provider, right? So they have to call the provider, get a whole new prescription, process it again for the second time through insurance, and now they're met with that approval that was really already on file.
So, is that just their internal policy?
Internal policies. All the specialty pharmacies I've seen, they don't accept our transfers from retail pharmacy. I work in Georgia though, so don't take my word for that. All right.
I'm sorry.
Go ahead.
Would there be a way to push that?
What's that?
Provider or the patient push that?
If they know which pharmacy to go to. That's the issue here. They don't know which specialty pharmacies they go to. A lot of specialty pharmacies, they have their own field teams, right? They go out and they try to, I don't know, contract with those specific provider offices. Hey, come and send all your prescriptions here. We accept these insurances. It's up to the provider to decide if they accept that specialty pharmacy or not. And so if they don't know which PBM approved pharmacy they have in the area, whatever specialty pharmacy they have a contract with at that time, they'll just send it there, not even knowing if that particular patient's insurance is even covered or taken there.
Yeah. I guess my question was
Right.
for the patient's behalf. If they took the prescription to you and then you had to send it to the SP would accept that and wants the provider to write a new.
No. Yeah, the patient they'll accept a patient, like a handwritten prescription. Is that what you're meaning?
Didn't you just say that the SP requires another prescription?
If it was transferred from another pharmacy. So so
I understand. I feel for the patient in this matter because that delays their treatment.
Exactly.
That creates more internal paperwork for the office to do duplicate processing.
Right.
something they already did, and it's one healthcare provider or treater pharmacy to another. I don't know, it just seems redundancy.
Redundancy and very confusing, right? So the patient, every pharmacy, they're going to call the patient and say, hey, we have a prescription ready for you. We have this prescription. It costs this much for this patient. Now the patient, they're going to call their provider, their doctor, and they're going to say, hey, why am I getting random calls from pharmacies I've never worked with? And they're telling me about my health plan. They're telling me about my health care. I have no idea who these people are, and now you have them calling me, right? So that also increases the need for transparency, for collaboration, for communication.
So Kiana, so this, if I have a prescription, I go to my local CVS, it's a specialty drug, CVS can't fill it, but CVS sends it to Accredo will say, no, Shannon, you need to go back to your provider and have the provider send this to Accredo. Is that
That's an option. That's like the roundabout way. If I was a pharmacist at CVS, well, CVS has their own specialty pharmacy. So they probably, if you went to CVS, you probably already know that CVS takes your insurance. So they'll probably just send it to CVS specialty pharmacy. But let's say I worked at CVS and I wanted to send it to this other specialty pharmacy that's non-CVS,
okay?
right? I try and transfer it. Pharmacists, you can transfer over the phone,
Okay.
prescription to prescription. But I called this new pharmacy. I said, hey, I have a transfer is for the specialty medication. That pharmacy will say, hey, we don't accept phone transfers. We don't accept transfers from community pharmacies. We need a new prescription from a provider. So then either that pharmacy will call the provider. I would call that provider as a retail pharmacy. Honestly, I probably would not because we're so busy on the retail pharmacies, or the patient will do it. The patient will speak out.
Understood. So thus the delay.
Thus the delay and the confusion in that communication train. Mm-hmm. And then the last bullet here is possible delays in transportation of specialty medications. Commonly with specialty medications, they're transported to preserve their efficacy for at least about 72 hours, right? So imagine all of these delays are occurring, and after those 72 hours are up, they're still nowhere to be sent. Now we have damaged medications, and we know these specialty medications are not cheap. They can range up into thousands of dollars. How can we improve the journey of the pharmacist or of the specialty pharmacy, of the retail pharmacy? Clear patient communication. We've mentioned that already plenty of times, right? Understanding the patient's network, understanding the preferred pharmacy, again, to save time, save that confusion.
What other question, just around it's an urgent situation, trying to get a prior authorization? It's just in terms of urgent review. In some cases, like if you're trying to get a PA approved and get a denial, you're trying to go through like the second level. Is there a way to get an expedited review, or what are the?
Yes. So for everyone listening here, they're asking, there was a question that came in about expedited reviews. Is this a thing? Yes, they have emergency, I don't know the official term for them, but they do have emergency processes. Each PBM, they do have that. Okay. How do I put that? What is the Porter Key Code? Okay, so has Healthcare Advocate Summit. There, I've seen a lot of Cover My Meds signs. So I'll use Cover My Meds for example. So Cover My Meds is one portal that's used to process prior authorizations. And for each prior authorization that's submitted, there's a particular key code that's only for that specific prior authorization, right? The only person who has that key code is really the person who submits that prior authorization or who's working on it. But those key codes, that's how you check the status. Cover My Meds, you can refresh and you can check the status. Where is it with the insurance plan? Has it been approved yet? Has it been denied? So you saw in the previous slide I mentioned sharing those compliantly. Share those with your whole team, your entire staff. Share that with the specialty pharmacy that you work with who also uses Cover My Meds, who they can then use that same key code to check the status, to minimize the need of the back and forth communication, to minimize the need to keep calling the provider's office and checking on that status. All right. So we've gone through each of these key players here at the bottom, right? Patient, physician, pharmacy. Now we're at the bottom or the top. The last player, the payer, the PBM, the health plan. All right, so a lot of people I mentioned have a lot to say about PBMs and how they can do better, especially with the recent investigation by the FTC. But with the payer journey, there are really only just maybe two outcomes. They either approve it or they're going to deny it. But I kind of wanted to talk about administrative denials here because it's not a common term and a lot of people don't understand or really even know about administrative denials. So, with administrative denials, they're different than the typical proper denial. Sometimes PBMs they require more information, right? You submitted that prior authorization and now they request the provider for more information. And sometimes those requests come with a deadline, soft deadlines of about, let's say, 36 to 48 hours. Many do account for business hours in that deadline, but some do not. And so let's say if a request for more information is sent to the provider Friday afternoon, by Monday, that prior authorization has been denied because they did not receive that information. Now, of course, on Monday, the provider is still going to resubmit that claim. They're going to submit that information. And so it'll still be approved or seen by the PBM nonetheless. So, not a problem. But where the issue lies is that the patient is now lost, right? So, let's say that the patient, they wanted to check in into the health plan. Hey, health plan, what is my status on the specific prior authorization? Many PBMs within their infrastructure, they do not have clear definitions or clear denials labeled. So they don't have the difference between administrative denial and then a proper denial. So the patient calls their health plan asking for their status. All they're going to get is, hey, it was denied. So the patient's upset. The patient says, hey, I'm not getting my medication. Let me call my provider, see what's going on. Remember, the provider, they submitted their information. So if they call the provider is going to say, we've submit more information. We're still working on it, patient. Now the patient's confused. I'm getting two separate forms of information. Is it denied? Is it not denied? I'm getting paperwork from denials. I don't know what an administrative denial is, but my provider, they're telling me they're still working on it. What is really going on? Alrighty, 2 out of 3 drug launches in the next 5 years, that was the fact, are predicted to be specialty medicines. So we know that with drug development going the way that it is, the more specialty medications that we see come into the market, the more we need a revision to market access and patient access and reimbursement policies for these medications. So what's next? How can we improve the payer's journey? Right? So increase the clinical training of all their reviewers. Many times we hear that they try and call these health plans, these health insurers, and the authorizers, they have no idea what labetalol is. I don't know, some random medication. They have no idea what it is. They don't know anything about the disease state. They get a prompt that says, deny this if you don't have these levels of information, and that's it. So on the payer side, increasing the clinical background, increasing this training of all of their reviewers. A regular prior auth program review. Undergoing this regular review, we can use data analytics, new clinical data, to really decide and see which medications over the past few years or in the past 12 months have the lowest rates of denial. If they're consistently having low denial rates, what's really the need for always having this medication in your prior auth program? Then, of course, increase notification to not only just a provider, but also let the pharmacies and the patients know to build this consensus. All right, so we've gone over every player here. We've gone through all of the arrows within this prior authorization process. And of course, I mentioned the goal of this educational session was for you to take home and to be able to hold your own in a conversation when it comes to this debate of what will the new process look like. All right, so if we take away all of those arrows, how would you redraw this process? How would you make it easier? How can we redraw this process? I sat into a session today on value-based care. I see that this is kind of like a hot topic, especially at the summit here this week, is value-based care. Will value-based care be used to determine which physicians are elected or selected for the prior authorization program? If physicians are consistently prescribing based on clinical practice guidelines or using evidence based medicine, are they still required to go through those common prior authorization programs? Again, I'll leave you with the question of what does this new improved process look like to you? And that's actually all that I have for you guys today. So if you have any more questions, we still have a few more minutes. Any questions online or in the room? Sure, go ahead.
The PBM approved specialty pharmacy, is there a place where you can go find that out?
Yes, so the PBMs themselves, they actually have all of their specialty pharmacies. Some of them have them online, but on the plan benefit comparisons, every year when you have a new fiscal year, you're ready to enroll. On those plan benefit comparisons, you usually see your retail pharmacies that are accepted. Now they're starting to introduce those specialty pharmacies based on your location.
What are some resources that manufacturers could provide providers to help navigate the PA process?
It's really good. On the pharma side or manufacturer side, you have a reimbursement team, right? Those field reimbursement managers or even your sales team. These are those who are interacting the most with the providers and the staff there anyway. So supplying your field reimbursement team, the ones who are on the field, who are speaking to the physicians, who answer your physicians' questions, educating them and providing them with materials and not acknowledging what they do with the providers so that they can assist them better.
I think there's something in the swag bag that you got when you checked in on navigating prior auths.
And there's a swag bag. And I sat into a call today about navigating the patient journey. Any other questions? Any questions online? Okay. Well, again, I'm bright orange today. If you have any questions about the session today or the PACS program, please hunt me down, find me on the app, and I'll be glad to answer your questions.
Your form for the CEs?
So it's all online. You'll fill out the form online on priorauthtraining.org.
Yeah, question. So we want to move our team to the PA. I want to do it. So how long would you say I should allocate time-wise? Because it's crazy busy. Like, right. So, and so we worked with Annie. Yeah. So I had told Annie that we want to do this, but I have to do it first because I got to get to the program. 2 weeks. So 2 weeks, RJ. 2 weeks. I just said, well, it's asked to go to knock it out 3 weekends. That's what I'm thinking.